In today's video, we'll discuss about pleural effusion. So basically, what is pleural effusion? It is the accumulation of serous fluid. The serous fluid can be either transudate or exudate in nature within the pleural space. Now, in etiology, basically either it can be without the involvement of pleura or with involvement of pleura. If it is this, basically it is due to passive transudation. And if it is with involvement, then it is exudation. So over here we have a number of reasons. It can be congestive cardiac failure, constrictive pericarditis, then nephrotic syndrome, cirrhosis of liver, hypoproteinemia. Now, in cases where the pleura is involved, the cases are like tuberculosis, pneumonia, or malignant metastasis involving pleura, or it can be due to pulmonary infarction. Also, it can be due to pancreatitis, SLE, rheumatoid arthritis, lymphoma, Meigs syndrome, subphrenic abscess, and so on. Now, since you know that there is an accumulation of the serous fluid, so what is the pathogenesis? Either there is the increased production of fluid by infection or due to inflammation. Then there is decreased absorption by pleura. Then there is increased hydrostatic pressure. Then there is increased capillary permeability. Also bleeding into pleural space. This is basically in cases where there is malignancy or hemothorax. Okay, now these are the basic steps that are involved in pathogenesis. Now coming on to the clinical features. In clinical features, what you will see is you will see dry pleurisy, pyrexia, dyspnea, also chest pain. Now coming on to the physical signs. In physical signs, what we see is that the chest is not palpable the same way. So what we will see is first in physical signs, first of all is inspection, then is palpation, then is percussion, and then is auscultation. Okay, now first of all, coming to the inspection. In inspection, what we see is the chest, it is bilaterally symmetrical, but there are restricted movements. Now in case of palpation, what you will see is that the trachea and mediastinum, they are shifted to the opposite side. Then expansion of chest, it is diminished. The vocal fremitus is also diminished. This was also diminished in one more thing. I have made a video on it. It was in pneumothorax. So yes. Now coming on to the percussion. In percussion, what we see is there is a stony, dull sound when we do percussion on the affected side. Also, it can be rising dullness into the axilla. Then coming on to the auscultation. In this, the breath sounds, they are normal. See is there is amphoric bronchial breathing, at apex of pleural region. Then pleural rub is heard above effusion. Now, coming on to the investigations, the foremost investigation that we will do is the chest of X-ray, X-ray of chest. So, in this, what you will see is there will be a uniform dense opacity with upward concavity in lower and lateral part of hemithorax. Then there will be obliteration of costophrenic angle. Also, in interlobar fissures, what we will see is there will be phantom tumors. Okay, now coming, then we will do the blood examinations to see the underlying cause. Then we can also do the ultrasonography. Then pleural infusion, that is paracentesis. We will take out the around. We will take out around, I think, 150 to 200 ml of the fluid, and we will see. We will examine the fluid, and by the fluid also we'll come to know what is the underlying cause. Also, pleural biopsy can also be done. Then other investigations like bronchoscopy, thoracoscopy, scalene lymph node biopsy, serological test for rheumatoid factor. Now coming on to the treatment. In treatment, what we see is, first of all, we will aspirate the aspiration of fluid. Now, this is done due to a number of reasons. First of all, is for the underlying cause. Second, diagnostic process, that is same. Then to relieve the dyspnea. Then also, if there is no response to the treatment, and if the fever and toxemia they do not subside after 4 weeks of the anti-tubercular therapy, then we have to treat the underlying cause. If it is tuberculosis, give anti-tubercular drugs. If it is malignant pulmonary effusion, if it is malignant pulmonary effusion, then we have to do repeated aspirations. Also, if it is unavoidable, then we will do the pleurodesis. If it is amoebic liver abscess, then we will see that there will be a chocolate brown colored fluid that will come out, so we will give metronidazole or chloroquine. So this covers pleural effusion. In one video we'll just discuss about the certain characteristics of the fluid which has been aspirated. So thanks for watching. I hope you understood it.